Hello everyone, and welcome to our training on avoiding unwanted interventions. My name is Victoria Tippins. I am a childbirth educator and I've been attending births for 15 years, and I'm also the creator of the Peaceful Birth Method. Today I would like to talk with you about different ways that you can avoid unwanted interventions during your birth. So I'd like to start off by talking about the evidence practice gap. There is something called an evidence practice gap, which means that it takes many years, sometimes even decades, for current research and evidence to make its way into policy. When we are aware of this, we're better able to have more positive experiences in the hospital and make informed choices in alignment with our values, choices that are based in evidence, and we're better able to go through birth with access to more options instead of less. So since it takes so long for current research and evidence to make its way into policy, what can happen is that, there are some policies and procedures that can be recommended that really are not best for you. In the Western medical model, there is something called a conveyor belt model of care. A lot of people call it that, which means that you go in and you follow whatever kind of algorithm or policy is put in place and kind of just do what you're told and go along this conveyor belt. This is not a personalized model of care. It is a conveyor belt model. So it means that everybody fits into this kind of category. If this happens, if your water breaks, you get Pitocin, right? We're all following these laid out algorithms, and there is no personalization. The problem is that when we don't have personalization, choices are being made for us, or we can feel like choices that are made for us without really considering what our preferences are, what our intuition has to say, how we're feeling about that thing. And all of that is so important in helping you make the choice that really feels best to you and helping you have a more positive experience, because everyone is so different. Like, for example, if your water breaks before you go into labor and you feel like you want to do something to try to encourage your labor to start, if you were to go in and get Pitocin right away, if they said you have to get Pitocin because your water's broken, and no one is really considering that we haven't given you all the information about Pitocin, no one is considering that Pitocin can make your contractions more painful, and that might mean that it might be hard for you to have an unmedicated birth, and no one's considering that you really want an unmedicated birth, that's what your whole heart is set on. If we could acknowledge okay, this person wants an unmedicated birth and we want to do something to encourage their labor to start, what if we look into these other tools instead of Pitocin that don't come with the same kind of risk of making your labor more painful to support that mom and increasing the chances of having the kind of birth that they want to have? So that's just one example. Personalized care is taking into account your whole person, your intuition, your preferences, how you're feeling, your family history. There are another example, there are lots of families where the women and the mothers will carry their babies to 42 weeks, and that's just what they do in their genetics. It is just that all the women tend to carry past their due date or past 41 weeks, and that's their normal. If that person with that kind of normal were to hit 40 weeks and suddenly it's a problem that they're at their due date, in a non-personalized care approach, we would be pushing that person to get an induction because it's our policy that we start offering and talking about induction options at 40 weeks or 41 weeks, for example. But if we were to ask that person, what does your intuition have to say? How are you feeling about induction? How are you feeling about staying pregnant longer? What kind of birth do you want to have? What is your family history like? What do the women in your family do? How long do they carry? That can help us make recommendations and to help us make choices in alignment with our values and our preferences and what it is that we really want to experience for our birth. So the evidence practice gap is a term that illustrates the way that many hospitals practice today, which is through this conveyor belt model where policies and algorithms are kind of leading the way, and many of those policies are not based in evidence. And the reason why is because, like I said before, it takes many years, sometimes decades, for current research and evidence to make its way into policy. And the people who are creating the policies are often not the care providers, but higher ups in the hierarchy of care, in the hierarchy of the hospital model. And the people that are higher up have to think about liability, and they have to think about convenience, and they think about profit, and all of that does impact the policies that are made. So one of the reasons why our intervention rates are so high in the United States is because there are many policies woven into place that people and care providers follow along, and those policies are rooted in in profit. The hospital does make more money when they perform more intervention. Right now, our C-section rate is over double what the evidence-based C-section rate is. The episiotomy rate is also much higher than what the evidence-based rate is. The evidence-based cesarean rate is 10 to 15%. The evidence-based episiotomy rate is 1%. And the induction rate is about 30%. I'm not sure what the evidence-based induction rate is, but it is very, very high. And it is not that 1/3 of moms don't know how to go into labor, like their bodies don't know how to go into labor, but it is that there are many non-evidence-based reasons, and some of that falls down, is due to policy, that people are being recommended getting an induction and being pressured into getting an induction. Or for cesarean, there are many non-evidence-based reasons to perform cesareans on moms. So today we are going to talk a little bit about what some of those specific practices are or policies are that are not evidence-based, so that you know what the research and evidence actually has to say. We'll talk a little bit about interventions and my approach for advocacy. So I have a whole framework for advocacy that I've shared before in another live training. Today we're specifically going to talk about ways that you can reduce your risk of experiencing unwanted interventions. And so number one would be to learn the research and evidence and to understand what the research and evidence has to say so that your options can open up. So let's talk about some examples. So one example, like I mentioned before, is your water breaking. So if your water breaks before you go into labor, what can happen is that if you call your provider and you tell them, like, my water is broken, they might say, we want you to come in right away or come in very soon to start Pitocin. So this policy of wanting you to be in labor within 24 hours, sometimes earlier, it comes from the 1950s when providers weren't washing their hands in between caring for different laboring patients. And so they were spreading bacteria. And so babies had very, very high rates of death at that time. And we found out the reason why is because if your water broke before going into labor, those babies were getting infections. But back then we didn't know that we were causing those infections. So if your water bag had been broken for 24 hours before going into labor, we found that your baby was much more likely to have a negative outcome, which is why we want to start Pitocin as soon as your body goes into labor. But we were causing that. So now that we know that, now that we wash our hands, we wear gloves, we wear sterile gloves. If your water were to break, there are precautions that you take to reduce your risk for infection. If all of that is happening, what the research and evidence has found is that for most people who fit the criteria, you can wait 48 to 72 hours without increasing the risk of infection to baby. And I get this information from evidence-based birth. So not everyone fits that criteria. One piece of the criteria is if you have GBS or if you don't. So GBS or group B strep is a bacteria that they'll test you for. Your provider should test you for between 36 and 37 weeks. And if they find that that bacteria is present and you do have GBS, then the evidence-based timeline for if your water breaks before going into labor is 18 hours. So if you're not in labor by 18 hours, the risk of baby getting GBS infection goes up. So if someone had GBS, waiting much longer carries more risk compared to someone who doesn't have GBS, if that makes sense. So that is one tool to be aware of, I guess one rule to be aware of. The next one that I wanted to share, or actually before I go on, I will say with that one, your body will go into labor most of the time on your own if your water breaks and you're just kind of waiting for spontaneous labor. Sometimes we do need a tool to help us go into labor, but most of the time the body will. 85% of moms will go into labor within 24 hours after their water breaks. But I've found what can happen sometimes is that our water breaks and then we get really stressed and we're like feeling stressed and overwhelmed about when labor is starting or feeling pressure to get an induction. We don't want to get an induction, and all that stress can kind of keep labor off, right? Like it can keep labor away. So I find that it's really, really helpful if you are noticing your water is breaking and you're navigating what it is that you want to do, to make sure that you are, before you move forward with whatever choice, whether it is to wait for spontaneous labor, whether it is to use a tool, whether that be a natural tool or a medical tool to help you go into labor, that you are feeling connected to yourself and that you're making that choice from an informed place, meaning you understand the risks and benefits to both ways, and you're feeling love in your body before you make that choice. So we don't want to make choices from fear. Instead, we want to make our choices deliberately from a place of love in alignment with our values. I find that that really is the best approach to take in terms of like when we're deciding how we're going to go forward about things. So that is one example of the evidence practice gap. The next example is failure to progress. So one of the reasons why our C-section rate is so high in the US is because of failure to progress, which many people have described as a better word for it as failure to wait. And I agree, it is a failure to wait. Failure to progress became so popular throughout the 1900s because of the later 1900s, because of a doctor called Dr. Friedman, who was performing non-evident, maybe, how do I say this? Non-consensual cervical exams to 500 white women in a hospital in Boston, and who were put to sleep through labor with a mixture of morphine and scopolamine. And so through that whole experience, after checking all of those people, he created something called the labor curve. And the labor curve is supposed to be a curve or a timeline for how we should be dilating in labor. And this curve does not at all apply to today. A sample of 500 white women, it does not apply like what their cervix were doing in labor, who were young and who were also put to sleep during labor. It does not apply to people of different race and ethnicity, people of different age, people who are having unmedicated births. But we decided to have that be the standard, for how our cervix should be dilating in labor. So by following the Friedman's curve, many providers were diagnosing someone as failure to progress because they weren't meeting this very restrictive and non-evidence supported, horribly conducted research. In 2014, ACOG updated their guidelines to allow more time during labor, to say that it actually, based on more newer research and evidence, that it is totally normal for someone to labor even longer than we were thinking was okay, based on Friedman's curve. And then a few years after that, more research came out illustrating how many hospitals, still half of providers specifically, were still diagnosing failure to progress based on the old Friedman's curve instead of the updated 2014 ACOG guidelines. So the next piece that I want to talk about is the suspected big baby diagnosis. So if you have been told that your baby is measuring big on ultrasound, it is possible that your baby actually isn't big. So ultrasound is only effective at identifying fetal weight about 50% of the time. So if your provider tells you your baby is big and we should induce you, they're not practicing in an evidence-based way. ACOG does not recognize a suspected big baby as medical indication for induction. So that means that if you have a baby that is measuring big, there's a 50% chance that your baby is big, and there's a 50% chance your baby isn't big. And so if you were to get an induction, or if we were to induce everyone with a suspected big baby, half of those babies would not be big. And of course, there are very rare circumstances where a baby can get very big and where it can cause complications. That would be something that is more common if you had gestational diabetes and it was not diet controlled or it wasn't diagnosed. It's very, very rare that your body will grow a baby that it can't birth. So this is another piece where it's really important to recognize that there are policies or standard ways that providers practice that aren't based in evidence, that aren't even based in ACOG guidelines, and often cause a lot of stress and feelings of limitation and option for parents. If you ever were to come across a recommendation that doesn't feel good for you, you can always ask for another opinion, preferably from a care provider in a different facility who might have different policies that they're operating around, because every hospital has very, very different policies and every practice has different policies. I know hospitals that routinely do intermittent monitoring. That's just the way that they monitor for low-risk moms. I know other hospitals who routinely do continuous monitoring and really fight anyone who wants intermittent, even though they're a good candidate for it and it is an evidence-based choice. So these are just a few examples of the evidence practice gap. Next, I want to talk a little bit about interventions and the use of interventions. So in my content and everything that I share, my intention is never ever to tell you what to do. I'm not telling you what to do. And I'm not telling you to decline an intervention, because interventions can be life-saving. I use interventions with all three of my births. I used induction tools. I had home births, but I used induction tools for different reasons with all three of mine. I used cervical exams. Of course, I got monitoring. In some of my births, I wanted Pitocin afterwards to help me control bleeding. So I found that for myself personally, personally, picking and choosing the intervention that felt right for me was a really, really great approach. It is okay if you want to go into labor and have your provider recommend this intervention or that intervention and to just do whatever it is that they recommend. That's okay. What I'm trying to illuminate here is that some recommendations can come from liability, inconvenience, and profit-oriented policies and might not be the best thing for you. So one approach that is optional that you can take is to instead make informed choices in alignment with your values, looking at the evidence, which we talked about a little bit, looking at the options, right, around those interventions, and then having the tools to be able to communicate that with your provider. So now talking about interventions, informed choice means that you understand the risks and the benefits and the alternatives before you make that decision. And that's very important. We can't give consent to something if we don't know what it is that we're consenting to. Or it's not consent, in my opinion, if you are being pressured into doing something and if you feel that the option to say no is removed, like if you were to say no, that you would be punished somehow. That is not consent. We must give consent out of our free will, knowing that we have many different options and that we would be respected and treated the same no matter what option we choose. So next, let's talk about tools for saying no to any intervention you don't want. First off, I like to recommend that my moms do some preparation with advocacy beforehand. And a great way that you can do that is to create a birth preference sheet and allow that to be your advocacy tool. The birth preference sheet is not an illustration of exactly how your birth will go. It is an advocacy tool. So it's a place where you can get down on paper what your preferences are and make sure that your team are aligned on those preferences or at least understand them. It is absolutely ideal to find a care provider who really aligns with you, who you trust, who you feel safe with, who you agree in their birth philosophy. It is worth it to travel to find that kind of provider. It is, if you can. If there's better providers that you can access that might be farther away. Everyone has different access to care providers. Some people have access to midwives and some people don't. Some people have access to providers who offer breech vaginal birth, which is another example of an option that is removed from us due to liability and policy, even though it is an evidence-supported choice for most people and a safe choice for most people with a skilled provider. So some people will travel if their baby is breached. Some people will travel to find midwives. I know a mama who traveled 2 hours to just get a different provider that was better because the hospital closest to her, which was also 40 minutes, was still far away. Her care there wasn't very good. So it's worth it if you can. We want to bring our birth plan to our provider with someone who can advocate for you, who can be there with you so you're having the conversation not alone if possible. And I would recommend using language in your birth plan that keeps the power in your hands and leaves less up to provider interpretation. So if you were to say, I prefer to have the freedom of movement. I want delayed cord clamping, please, if that's okay, if my baby's safe or whatever. That kind of language is giving a lot of power to the provider. So instead, I would say, do not cut the cord until I tell you it's okay. Or I would say, I will move freely throughout labor. I will labor and birth in whatever position I choose. Just saying what it is that is important to you instead of asking permission. You don't have to ask permission to say no to anything. You don't have to ask permission to labor and birth in whatever position you want. You don't have to ask permission for anything at all because this is your body and this is your birth. A few more tools that you can use to help you communicate with providers is to first be really vulnerable and honest about what it is that you want. It would mean so much to me if I could have an unmedicated birth, or I really don't want cervical exams in labor. It would mean so much to me if we could avoid those as much as possible. Would you support me in that? And have a conversation. This is a way to be a partner in your care, to be collaborative, and to welcome your care provider as an integrated part of your team that you want to be on your team, instead of approaching advocacy as like, I have to fight you and I have to say no to everything you suggest, and you know what I mean. And I have a whole training on advocacy in my free birth course. The link is below if you want to check that out and learn more about how to have all those conversations with your provider and how to advocate in the moment. Another tool that I want to talk about is how to say no to something that you don't want in the moment. So if we've done some pre-work and now you're in labor, if your provider were to say, hey, I want you to get Pitocin, your labor is going kind of slow, for example. You could follow this tool called BRAIN. So you can say, what are the benefits? What are the risks? What are the alternatives? Also say, what does my intuition say? And what about doing nothing? What does that look like? Asking your provider those questions, asking yourself those questions can be helpful. And then I would send the provider out of the room to make the choice. Don't make the choice in the presence of the person who really wants you to make that choice. Just send them out of the room and talk about it with your team and feel into it. Feel what your intuition has to say. Feel love for your baby before you make the choice, to kind of help you make sure that we're not having sneaky fear come in and we're not choosing from fear. We want to be deliberate and make sure that we're choosing from a place of confidence and from a place of love. If a provider were to come to you and say, I think you need a C-section, and you don't want a C-section, nor do you see a need for one, you could say, am I okay? And if the provider says yes, you can say, is my baby okay? And if the provider says yes, you could say, well, then if my baby is okay and I'm okay, then I would like to continue with my plan for a vaginal birth. That is also an option. I just supported a mom recently in my birth class who was recommended a cesarean and went through those tools and said, am I okay? Is my baby okay? And the provider said yes. And she said, okay, well then if both of us are okay and our health isn't at risk, then we're going to proceed with our plan for vaginal birth. And then she had a vaginal birth, and she totally avoided a C-section because she had the tools, and she also had the confidence and the nervous system capacity and the support to be able to have that conversation. And so that kind of brings me to, I want to go to the next piece, but there's one more tool I want to share first. The next piece is emotional preparation, but let's just share this tool, which is to decline something in the moment. If a provider comes in and they say, time for you to push and get on your back. For example, if you are in hands and knees and you don't want to get on your back, you or your support person can say, nope, I'm staying in hands and knees. And if the provider says, but no, you're pushing, you have to get on your back for pushing so I can deliver the baby or whatever, you can say, I said no. So this is a tool to just decline again. If you're a support person, you could say, she said no, thanks for supporting us. Just simply with compassion and kindness and empathy, but also being firm in what it is that we want. She said no, she's staying here. That's it. So the next piece would be the emotional prep. So we want to focus on, just to summarize, what the research and evidence has to say, knowing our options around interventions. We want to have tools for communication and tools for advocacy. And then this last piece is the emotional preparation piece. And this is where my coaching program is so supportive for moms, because when we go in with the emotional preparation and the capacity, the nervous system capacity to be able to say no to anything that we don't want, that is really supportive. And so I'm going to talk about a few tools today to help you with that. Maybe I'll explain first a little bit. If we go into birth, knowing what the research and evidence has to say on our options, so we're aware of what our options are. If we go into birth with tools for advocacy, so we know how to communicate, those are really great steps to help us to advocate and avoid interventions that we don't want. But if you don't have the confidence in yourself and your decision-making abilities, if you don't have the nervous system capacity to feel safe in sharing what your preferences are, if you have a lot of fear that's kind of clouding your decision-making process, all of that can really impact the way that you proceed forward. And fear is what often leads moms to just, quote, giving up or giving in to something they're feeling pressured for that they don't really want and maybe isn't even the best thing for them. And this is where I really like to support moms, and this is where coaching can be so helpful, because then we can unpack the fear and we can process it and we can give you tools and personalized support and plans to navigate that if you're noticing that anything is coming up for you. When we learn a class, like when we learn birth information from an online class or an in-person class, or we read a book, all that lives in our brain, right? It lives in our mind. When you're in labor, you're not going to be drawing from your mind. You will be drawing from the body. You'll be drawing from whatever integrated place you've come to within yourself, whatever emotional preparation, the nervous system capacity, like movement of your body in different positions, the ability to relax and feel safe in the presence of normal biological labor. That's where we're drawing from. And that is what helps us feel confident going throughout birth, as like drawing from this place of inner confidence. So the first thing that I like to teach with this is to create a relationship with your fear. When your fear is something that feels separate from you, that you feel like you want to run from, that you want to resist and hide from, if you have a thought come up and you're like, I don't like that thought, and you want to like push the thought away and not have to think about it, that can sometimes lead to our fear living in the shadow and then popping up when we're in labor. So for example, there was a mama that I supported after her first birth. Her second birth was so amazing. Her first birth, she had a C-section because she was terrified of C-sections. And she told her provider how afraid of C-sections she was. And the provider was telling her that her baby was really big based on ultrasound, which we already learned in this training does not always mean the baby actually is big, and is not not medical indication for induction. But the provider said if you want to avoid a C-section, we should do an induction now before your baby gets too big. Also, it is very, very, very unlikely that your body would ever grow a baby that it can't birth. I know many moms who had 10-pound babies at home with no tearing and did amazing, and they were small, small women. So your body is very incredible and it knows what to do. This mom didn't know any of that, and she was so afraid of a C-section. And the provider was saying, if you follow my path, you'll be able to avoid a C-section. And so she said, okay, I'm going to abandon what I want for my birth so that I can avoid having a C-section. So she made choices thinking about and feeling what it was that she wanted to avoid, what it was that she was afraid of, and that took her directly towards a C-section from induction complications. So this is one example of how fear can really impact the way that our birth unfolds, because it impacts our decision making. It's like where your attention goes, energy flows. If your attention is on pain, you might end up creating an experience that is more painful because we're afraid of pain, and then we're tensing. We're like, oh no, there's pain, and then we're tensing, and then we're creating more pain, which creates more fear, which creates more tension, which creates more pain. And a lot of that could have been avoided if we had done the emotional preparation work beforehand to be able to enter birth feeling really confident and prepared. It doesn't mean that all your fear is going to disappear, but what matters is that you have support. You have people who know what your fears are and they can support you. You have tools to address your fear if it were to arise, and that throughout your pregnancy journey, you consistently worked to build a relationship with your fear and to love yourself. So one approach that I like to take is to turn towards your fear and feel it. So if you have a thought come up in your mind, like you're living your life and it's like, what if I tear? Or like, what if this thing happens? Or like that, if that thought keeps coming, it's because you have attention on that fear. And you have attention on that fear because there's emotional charge that's keeping your attention on that fear. So if you can work to process your attention off of that fear and then bring your attention to what it is that you really want to experience for your birth, that can really, really help you to feel more clear and confident. And if a fear were to arise, it won't feel like reality. You know how fears come up and it feels like reality because it's like so big and it overtakes you and you don't know how to address it. But if you're like, oh, my mom told me the scary story about how I was born and this one specific thing happened, maybe she tore and it was really bad. And then like she had pelvic floor dysfunction and I'm terrified of that happening to me. So now I have all this fear around tearing. If you were to be like me with my first and not work on your fear, then in the moment when you feel all that pressure from baby coming through, you might be like, oh snap, I'm gonna tear. I'm terrified. And all this fear comes up and then you just push, add extra pressure to get the baby out because you're afraid and then you tear, which is what I did. But if that is if like that story, that example that I gave is true for you, of like you heard the scary story of tearing or whatever it is, but then like throughout your emotional preparation journey when preparing for your birth, you build a relationship with that fear and that fear comes up and you go, oh, hi fear. This is a part of me that wants to tell me something. What do you want to tell me? And you process it and you get support with it. And then you realize like, okay, I have this fear coming up because of my mom and her story or this thing that I heard. And so I know what the fear is now. I know where it comes from. My birth team knows what it is and they know where it comes from. Now we can create a plan to help me to prepare and to feel confident in that area. And if that fear comes up in that moment, we have tools and things that we're going to work on. And then if it does come up, it doesn't really feel like reality. It just is like, oh, hi, you. I know you. I know you. I've been working with you and here you are again. And you can't hurt me, right? Like there's no part of you, no fear that can come up within you that can hurt you because everything that you are, every part of you is perfect. And if there's a part of you that's coming up, it's just a part of you that's ready to grow, that's ready to be loved, that's ready to be seen and processed. So if you can look at your fear, turn towards it and allow yourself to feel it, allow yourself to approach it with curiosity and bring it all into the light of your awareness. This is the opposite than what we want to do, right? Like we want to be like, go away. But if we can choose to truly, with curiosity and interest and love for ourselves, when we have things come up, voice it, bring it out into the open so it's not living in the shadows, that is a really, really great way to support you in building that confidence. So that when you go into birth and a provider comes in and they say, I think you need a C-section, and maybe you have a fear of C-section, instead of operating from your fear of C-section and feeling triggered in the moment and overwhelmed and crying and like having to process all of that during your birth, you can go, okay, I have this fear and I have tools around it. We're going to use these tools. I'm feeling like a little worried right now. We're going to use the tools. We're going to like process and I'm going to feel okay. And when I'm feeling more clear, then I'm going to make a decision. And then we can begin that conversation from a place of feeling more calm instead of feeling really triggered and afraid and like things are happening to you out of your control, which sometimes is how we can feel when we go into birth. So those are the three like branches that I like to support moms in knowing and checking off, like checking the box when they're preparing to have a birth where they're wanting to avoid interventions. Now, maybe I'll summarize really quick again. So that was research and evidence, right? Knowing your options on interventions. That was learning tools for advocacy, and then the emotional preparation. The next piece that I want to talk about is your rights in the birth space. You have the right to birth in whatever position you want. You have the right to say no to anything that you don't want, and you do not owe anyone an explanation or justification for any of your choices. It is simply that you made that choice. Birth is a personal experience, and so the algorithm of policy and intervention on that conveyor belt doesn't fit for everyone. It's not going to be the best thing for everyone. It will be the right thing for some people, but not for everyone, and maybe not for you. And if it's not right for you, that's okay. If you don't want any cervical exams, that's okay. There are benefits to getting cervical exams sometimes, and there are also risks. What matters is that you are making the choice, knowing what the risks and the benefits are of cervical exams, feeling confident in yourself, and having tools to communicate that choice with your provider. So you're coming from a place of confidence and love for your baby and respect for your experience and what feels right for you, instead of feeling like you just have to comply and do whatever it is that you want to do. Anything as like simple as getting an IV in labor to as great as having a cesarean are all choices for you to make. And once again, I'm not telling you to say no to any intervention, and I do recognize that interventions have their place and they are necessary sometimes. And it is very clear in the research that non-evidence-based intervention rates are running rampant and growing in the West, and outcomes are not improving. The US has very high rates of maternal mortality, one of the highest of all developed nations. And still, we have very, very high intervention rates. So it's kind of interesting to look at that. Intervention doesn't always mean safety. It just means intervening. It means we're intervening, and sometimes we need to, and sometimes we don't. We have been conditioned in the West to believe that more intervention equals more safety. And a lot of moms come to me and they say, I want a normal physiologic birth. I just want a pretty hands-off, low intervention, normal birth. And that feels so hard. They feel like they have to fight so hard to get that kind of experience, to be supported in that. They feel like, am I a good candidate for that? Is that going to be safe? But that is the norm. Right? A normal physiologic birth is the norm. It is you listening to your own physiology that has been perfected over thousands of years of evolution. And yes, like we can step in with interventions and save lives because sometimes like that can be needed, but intervening from beginning to end throughout the entire birth comes with risks. And when we intervene, sometimes those risks can become present, and that can lead us down a path that we didn't want to go down. Your body knows what to do, and your baby knows what to do. And I think it's a really helpful place to, in your birth prep, like a helpful step to explore within yourself, what's your relationship with control? What's your relationship with intervening? Do you feel like you can trust the normal physiologic process of birth and let go and let your body guide the way? Do you feel like you can be okay not being in control? It's this illusion of control where we are controlling when labor starts, and we're doing all these cervical exams to constantly check progress in quotes, and we are trying to manipulate every little thing so that we feel like we're in control. And that's often coming from a place of just being worried about birth or feeling nervous about birth, and so we feel a little better when we're in control. But it's just an illusion, because either way, whether you're trying to control it or not, you're still out of control when we're in birth. We still don't have control to a certain point. We have the control around the container we create for our birth, around the kind of preparation we have, around the people that we choose, around the choices that we make throughout birth, around how we respond to it, if we choose to relax in the moment, if we choose to get in this position or that position, what pain management strategies we want to use, right? Like we have control over so much of that. But there is a point where we don't have control anymore. And I think examining that is a really helpful and important piece for you to do if you're interested in having a kind of birth where you're letting your body body guide the way. Thank you so much for being part of our training. It was lovely to have you here. And if you have any questions, feel free to DM me. If you are not in the Peaceful Birth Academy already, where you can access my trainings, my guided meditations, my full birth class, go ahead and click the link below. If you are already in the Academy, then you can go to the calendar tab and you'll see when we have our next trainings. And please DM me if you are interested in joining my coaching program, or you're curious to do a free birth breakthrough session with me. Definitely go ahead and DM me so that we can talk a little bit, we can schedule that session, and I can hopefully give you some support. Okay, thanks so much for being here, and you've got this.